So this whole presentation or this whole webinar is around one simple idea that hopefully regulation, if it's done well, can really help you as organizations improve the quality of your care that you provide, rather than just being another source of stress. So it's my pleasure to welcome Ron Lavater here today. He's the CEO of the International Hospital Federation, to say a few words before we start. Ron, over to you.
Thank you, Erik, and thank you to our two speakers, Jeffrey and Carsten, both colleagues that I've known and worked with and have a lot of respect. And the audience today in our webinar is really in for a great treat, because the information and the discussion is going to be a rich one with two very experienced individuals. I just want to say from the International Hospital Federation's perspective that our commitment to patient safety, to employee safety, to high quality care across the hospital landscape is something that is near and dear to our core mission here at IHF. As a membership organization, we have members in 75 countries across the globe. And we have a long history at the IHF. We started in 1929, so 97 years of a history. And I'm also very pleased that our relationship with ISQua goes back for decades. At least 20 to 30 years of collaboration with ISQua and the team there to help promote, good practice and the importance of accreditation. And making sure that all hospital leadership teams pay attention to the quality and safety within their organizations. So I won't say anything else except enjoy the session. Get ready for your questions for both of our panelists. They've got great experience. And thank you for joining us for this session today. Erik, back over to you.
Thanks, Ron. Thanks for the introduction. And thank you all for being here today with us. We call this the 70 years since accreditation started. I think it's a little bit more than that. Accreditation has been around for quite some time with the overall objective to help improve quality of care. And with us today are two presenters from ISQua. First of all, I'd like to introduce you to Professor Jeffrey Braithwaite. Jeffrey's a distinguished author and researcher himself. He's the founding director of the Australian Institute of Health Innovation at Macquarie and the University of Sydney, and chair of the ISQua Academy, and one of the authors of this excellent report. More than 1,500 publications, keynotes to his name, a very influential voice, and we welcome you here today, Jeffrey. Thank you for being with us. And second, Dr. Carsten Engel. Carsten is the CEO of ISQua, and he's trained as a physician in Copenhagen, spent a lot of time as anesthesiologist, and then moved into the world of accreditation, and where he's now been with ISQua for quite some time, since 2021. And again, Carsten, I'd like to welcome you officially to this webinar. Jeffrey, I believe, will start off with this presentation about the scope and method of the synthesis, about the publication, and then Carsten will take us into the findings, what it means for regulatory practice. And as I already said, at the end, we'll have some Q&A, hopefully. And Jeffrey, over to you. Thank you.
Thank you, Erik. Thank you, Erik and Ron and Tom and Aditi for the invitation. And I've been working in this field for a long time, but I'm a great fan of IHF and all the work it does. So it's an absolute pleasure working with you this morning, this afternoon, this evening, wherever you are. I'm in Sydney, Australia at the moment, and it's nighttime. If I happen to be waving my arms around, Erik, it will be because the lights have gone off automatically because it's after 7 p.m. So if I get all animated, it's partly my excitement and passion for the topic, but partly because I'm keeping the lights on after hours. So let me take you through what we're going to do. So we know that the theme is regulation, and we're going to talk about accreditation. And of course, accreditation is both a form of regulation a regulatory form, but it is also a quality improvement tool. And we're going to make that distinction and discuss that. Here's the presenting team, and the first three people are the smart ones because they delegated to Carsten and myself the job of presenting on behalf of all of us. So we're going to do a few things. We're going to do 6 things in total. We're going to briefly talk about ISQua and my institute, AIHI, because we want to frame what we say in the context of the organizations which we work in and support and know and love, because they provide the context for what we're going to say about accreditation. And then there's 4 parts, and then at the end, we're going to have time, we hope, to generate a Q&A. So, Carsten, would you like to just briefly introduce to the audience ISQua?
Yeah, well, ISQua is a non-profit membership-based organization that has been around for many years and is present in a lot of places. Next, please. And what we do is summarized in our tagline: knowledge, network, voice, action. There is a lot of knowledge in our network. A lot of knowledge is generated within our network, and it's our mission to give voice to that knowledge and make it accessible to all of the members of our network in order to generate action to improve quality and safety of healthcare around the world. Next. And when it comes to accreditation, a sibling company of ours, the ISQua EA, based in Geneva, is the accreditor of the accreditors. What we do is that we accrediting organizations like JCI, Accreditation Canada, and many others, and we assess them by 3 sets of standards: 1 to assess their standards, 1 to assess their surveyor training program, and 1 to assess the way in which they govern and plan and deliver accreditation services. And we've been doing this for around 25 years or a little bit more. And we're actually now at a point where we want to take accreditation to the next stage by revamping our accreditation program. More about that later.
And so the other organisation that we both work with and for is the Australian Institute of Health Innovation, headquartered in Sydney, Australia, but working essentially on or with people in 152 countries, low, middle income and high income settings. And the Institute's thing is innovation through research. So we're a research organisation. Just very briefly, we've got a lot of research centres. The 4 where you see pictures of people above them are university centres that go to make up our institute. And the ones on the right-hand side come and go depending on large grants, large research grants that we earn. So what you see in the titles of all of those grants and centres is what we do. It's essentially health systems research, quality and safety, informatics, health economics, all to do with a better health system. And here's a bit of a wave from some of our team in Sydney, Australia, to you, wherever you are in the world today. So that's by way of framing what we would like to say, Carsten and I, on behalf of the presenting team. So what did we know until recently about accreditation? So accreditation over the years has been innovating. It's become more professionalized, internationalized. People swap ideas about accreditation and standards these days. It's used as a tool for change, and I'm going to come back to that. Carsten and I have witnessed in our organizations and over the years as we've done research on accreditation that the standards that are applied have become better, sharper, more focused on improvement. There's a perennial debate about, is accreditation more to do with inspection or actually ongoing continuous accreditation? And there are also questions about how much should people self-assess, say hospitals, should they self-assess or should they be assessed by other means? So over time, what we've also seen is the use of algorithms to assess, for example, algorithms to go through clinical indicator data, and most recently with AI-enabled assessment, to see what the data is telling us. There's been also innovations in having patients as surveyors, not just professionals, policymakers, or clinicians as surveyors. There's been work in many countries on tracer methodologies, following a patient through to see what happens to them. Short notice surveys, people not scheduling surveys 4 years in advance, but coming at much shorter notice. And then evidence-based processes and standards is much more the case now than it was in the early days, where standards were kind of like what we thought was good. A recurring finding in all the literature is that good hospitals, good healthcare organizations use accreditation as a vehicle, a lever for change and improvement. And poorer performing healthcare organizations, they more do a tick box where they just want to get through accreditation, pass, and then move on. And so accreditation can really leave them relatively undisturbed, but they get the certificate on their door to hang in their foyer. So, to what extent is your hospital, as a member of the IHF, one or the other of those two? Let me just explain that. Here's a study we did in 2010, which illuminates that. We had a look at 19 randomly sampled healthcare organizations in Australia, and we looked at their performance on accreditation, their organizational climate, their organizational culture, the extent to which they involved consumers, these hospitals, in their clinical processes, in their decision-making. We looked at their leadership and their clinical indicator performance. So here's a question for you in the audience. Are these correlated? If you do relatively well, say, on accreditation, are you likely to have a good organizational climate, organizational culture? You're likely to involve consumers in your processes, and so on and so forth. So I'm going to talk about whether they are correlated, but just a note for you, a brush up on your statistics in case you are out of date. If you're going to correlate some variables, they can range from -1 to +1. And that measures the degree of a relationship between two variables. A perfect correlation is 1. A perfect negative relationship is -1. So here's a question for you. What's the correlation? What's the relationship between smoking and lung cancer? We know that smoking is a precursor of lung cancer. And if you get lung cancer, it's often attributable to smoking. But what's the correlation? And then the second question is, what's the correlation between passive smoking, say you live in a household where you've never smoked, but people in that house smoke and you've been exposed lifelong to smoking? What's the relationship, the correlation between that, passive smoking, and lung cancer? Just have a think about that. I presume you're going to say it's plus and towards 1 rather than -1, because you're going to think they're related. Well, here's the answer. The relationship between smoking and lung cancer is 0.72. It's not perfect. Everyone who smokes doesn't get lung cancer. And everyone who gets lung cancer, although most people who get lung cancer are going to have been a smoker, not everyone is. And the relationship between passive smoking and lung cancer is also positive. If you experience lots of passive smoking and you get lung cancer, there's likely to be a relationship. So in accreditation, now that I've anchored you to think about rank order correlation, the relationship between accreditation and having a good culture in your hospital is 0.62. And the relationship between accreditation and having effective leadership is 0.62. So that's just about where it's somewhere between passive smoking lifelong and smoking and lung cancer. So these are quite strong relationships. You rarely get this strength of relationship in organizational studies about hospitals. So the data show there's a highly significant relationship between accreditation performance and organizational culture and leadership, which means that if you have good leadership and a good culture, you're likely to get good accreditation performance. And if you have good accreditation performance and you tell me that, I'm likely to say you're going to quite strongly and likely have a good culture and good leadership, a positive organizational culture. And there's a trend relationship, pretty strong relationship too, between accreditation performance and your performance on your clinical indicators. So that's what we knew up to date. But now we'd like to provide you with an update. We've recently, Patel et al., one of our presenting team, Ramika Patel, who's in the audience, hi Ramika, recently led an AI-supported synthesis where we put together all the accreditation literature right across the world ever since inception, all the way to 2023, and we summarized it. And there's a QR code if you want to get this, but it's available also on ISQua's website and my institute's website, the AIHI website. Essentially, it says for many people, accreditation's acting not just as a compliance mechanism, but a quality monitoring catalyst. There's lots of factors influencing accreditation effectiveness, and I've explained some already in that earlier study. And there's a lot of work to continuously innovate and adapt accreditation to be more effective in very rapidly evolving hospital environments. There's lots of flexibility. More and more people are factoring in that one size doesn't fit all for accreditation, but we have to map accreditation and standards to the context that people find themselves in, because a hospital isn't just a hospital like all the other hospitals in the world. Upcoming, stand by, audience. We're just about to finish volume 2 of this literature, bringing all the literature on accreditation in 2024 and 2025 also into volume 2 of this series on an AI-supported synthesis of healthcare accreditation and standards literature. So no longer with the release of this second volume will you need to keep up to date with all the literature, because we've done the heavy lifting for you. We've summarized all the literature we can find in these 2 volumes. The second one will be released in the not too distant future, in about a month, we think. So that's what I want to say about what we know about accreditation now and bringing us up to date with these 2 new volumes. I'm going to hand over to Carsten now, who's going to talk about, well, what does this mean, this platform that I've helped lay about the future of accreditation? Carsten.
Thank you, Jeffrey. Well, I think that when we are looking at the future of accreditation, there are 4 trends we need to consider. The concept of quality has broadened, health delivery models are changing, systems understanding is developing, and new technologies are coming, or they are already there. So the first trend is about what is quality, and there's a gap. Well, there is a gap. The number of patients who are harmed by healthcare is still almost it is actually on the same level that it was 25 years ago when we began measuring it. That's one gap in patient safety. There's also a gap in effectiveness. Numerous studies have shown that while, let's say, about 60% of care is delivered in accordance with the evidence and established best practices, 30% is of low or no value at all, and 10% is actually causing harm. So there is clearly a gap, but the quality concept has changed. When I was a young physician many years ago, we implicitly believed that quality of care means doing the things I do according to high professional standards. Well, that's obviously still part of the truth, but there's more to it than that. Next slide, please. There are new expectations from patients. Patients don't want to be considered as objects we do things to. Patients want to be considered as persons we do something with. Person-centeredness has become an important component of quality of care. There's sustainability. We need to deliver healthcare in a way that's sustainable. New treatments are coming coming along all of the time. There needs to be equal access to all of these new changes, and there's a need for a safe and healthy workplace. Next, please. All of this has been summarized very well in the triple aim. The triple aim says that we should aim at the same time for improving patient experience, achieving better outcomes for the populations, and all of this at a lower cost. And one of the things I like about the concept of the triple aim is that it highlights that there is a need to balance. If we go for any two of these, we can do that easily if we want to sacrifice the third one. If we want to to balance the three of them, we need to make some trade-offs, some compromises, and it's very important that we make these decisions both involving both professionals, the persons responsible for delivering healthcare, and the patients who are the ones who knows what really matters. The triple aim increased over the years. We added the fourth aim, clinician well-being, and the fifth aim, health equity. Next slide. And you could consider adding planetary health as a sixth aim, the health of human civilization and the state of the natural system on which it depends. But actually, I don't think this is something that we need to balance against the others, because better outcomes for the population is not possible without improved planetary health. We can't have a healthy population on an unhealthy planet. So I think it might be more of a way to, let's say, expand the first of the aims. Next, please. The second trend is healthcare delivery is changing. Both supply and demand and opportunities are drivers that change the roles of the hospitals. I won't go deeper into this. You know all of this very well from your daily work. Next, please. But the essence of this is that the hospital's roles are changing. They will become more like knowledge hubs, and they will be, instead of the default places where people go, they will be the place where you deliver services that can't be delivered decentralized, but there will be a movement towards delivering more close to the patients through primary care and even in patients' homes. All of this needs to be taken into account by accreditation. Then there's systems thinking. Next, please. We know that healthcare is a very complex and adaptive system, and that has a lot of consequences. The relation between cause and effects are not linear, but there are positive and negative feedback loops and cross links. All of this means that the effect of a given action can't always be predicted precisely. An action at one place can have unintended and unforeseen consequences as at other places. The system is open, the borderlines are diffuse, and there's interactions with the environment that are not controllable from within the system. We can't understand the system just by understanding all of its components, and here's a reference where you can dive deeper into this if you wish. Next, please. You know the Plan, Do, Study, Act circle. There is a similar circle that guides how a complex system can perform resilient, which means deliver constant performance of even in the face of circumstances that are changing and working within a complex system. You need to be able to anticipate what might happen. You must monitor whether that actually happens. When something happens, you must respond to it, and you must be able to learn from your experience to be able to anticipate, monitor, respond better and better. Next, please. We could translate this into three domains for safety work. One is about routine service delivery, the things we do every day, the things that are predictable, things like setting up blood transfusions, administering medications safely, taking care of specimens and test results. All of these are predictable, and all of this is a domain where standardization has a great role to play. But there's also a domain of institutional readiness, and this domain ranges from day-to-day variations. Sometimes the emergency room is fuller than others. You will expect that from time to time, one or two nurses in an ICU will report sick, and all the way up to major crises like in pandemic. This is the domain of resilience. Here you need a good toolbox. You can't build answers from scratch. You need a good toolbox, but you need a team culture and insight in order to use this toolbox in a prudent way to manage whatever comes across. You need a toolbox, but you don't need a cookbook. Books accreditation will have to support you in that. But then you have innovation, and here AI requires new models for regulation. Next slide, please. And this is about technology. Next, please. Safe management of innovation, the way we did in with drugs of devices, assumed that we understood what the drug and device was doing. We developed it according to a given specification. We tested it, and then we assumed that it would work according to those specifications all of the time. We had post-approval monitoring place to be able to detect and adapt to unexpected consequences, but we would accept that approval processes take some time. That's the pace to try for safety. And once we have something in place, we can use it again and again, and it will perform as expected. Next, please. AI is different. While we can have a general understanding about how an AI tool works, we can't explain in detail what it's doing and what it will do in a specific situation. It learns and will change over time. Its performance is probably more context dependent than is the case for drugs and devices. So there are more challenges in extrapolation from one test case, the setting in which we tested it, to another. The rate of innovation is extremely high. We can't wait years for things to get approved. So we need to find new paradigm on which to base safe management of AI implementation and use. Next, please. So I have outlined some challenges. Next. What stakeholders say about challenges, and we recently, for ISQua, created a report to frame the development of the next stage of accreditation. The stakeholders identified a number of challenges. Healthcare provider buy-in. As Jeffrey said to you, the effect of accreditation is highly depending on how it is used. It can be used as an improvement tool, and it can be used just to get a certificate, but that won't give you much improvement. There's the concerns about increasing cost, proof of value outside the assessment cycle, standardization with global programs, and change in care models. Next, please. So we also know some areas where accreditation must be stronger: co-production, person-centered care, sustainability, digital health, and the safe and healthy workplace. Next, please. Today, the typical accreditation journey is repetitive and episodic. Once every 3 or 4 years, you examine against the same set of standards. It includes a comprehensive review of policies and written procedures, and it usually requires a lot of preparation by hospitals. Is this the work? Is this the way we want to do it in the future? No. Yes, please, next. We want to strengthen the patient perspective. We want a more data-driven an approach. We want more focus on outcome. We want it to be less burdensome. Perhaps accreditation can be more like a partner of your accreditation journey. I assume that we will still in the future see that the first accreditation will be based on a comprehensive review, but not so much based on your policies and procedures, but what actually goes on within your system. We already have AI tools that can assess policies and procedures against a set of standards, but we also have AI tools that can develop assess of policies and procedures that complies with a given set of standards. So do we want to have in a situation where the accreditors AI is checking whether the provider's AI did its job right? We probably won't. So we would have to look more what's going on, more focus on outcome, not judging you by your outcome, but judging you as the way in which you assess and improve your outcome. And once you have achieved accreditation, maybe the way to maintain accreditation will be more by a collection of micro credentials and an assessment against warning signs, and perhaps some element of periodic inspection as well, but not in the way it's done today. Next, please.
So we've said a lot, but we just want to summarize what we said, because when Ron, Erik, Carsten, and I were younger, we were taught, and I'm speaking for you, Ron and Erik, and I hope I'm doing a good job of speaking for you. We were told that what you do in a presentation is tell the audience what you're going to say, then say it, and then tell them what you just said by way of reinforcement. So let me summarize very briefly. Accreditation, it's clear from a number of studies, and we've given you a couple, accreditation of a hospital is linked to better performing organizations. They're more likely to get a good result on accreditation. Related to better clinical care. Doing well on accreditation is linked to better clinical care. It's also a predictor of good organization culture. Better leadership of a hospital does better on accreditation, and vice versa. But all of this is predicated on people using accreditation and standards wisely and well. So this is the summary slide finally, because Carsten put the case that accreditation is and will have to become different from what we see today. So it's less the panel on the left with periodic site visits and inspection and procedures and a focus on standards and inputs and insisting on people meet standards, to much more organically continuous improvement, data-informed, as Carsten evocatively says, in a collaborative partnership between the accreditation body and the standard-setting body and the hospital. And it needs to be not one size fits all, but responsive accreditation to the context within which the particular organization finds itself. And in that way, it will drive quality and impact. So that's all we wanted to say. We're happy and open for discussions, comments, questions, observations. Just want to acknowledge some people in my institute who I work with and who deliver all of this great research. And if you want to catch me, that's how you catch me. And if you want to connect with Carsten, well, he's all over the internet and can easily be contacted.
I've been tracking some of the comments, and I think one of the things that occurred to me is that there's a lot of research being done. You tracked about 70 years worth of data and research done. I'm sure there's very few organizations within the IHF community that can boast that they've done 70 years of accreditation. I doubt it very much, but maybe there are some. But to the point of maturity, did you see any difference between organizations that have had multiple accreditations or many years of accreditation versus ones that are kind of new to this game?
So I think there's two things. There's two answers to that, I think, and Carsten will have an answer too. One is there's often organizations or countries adopting accreditation for the first time often get a rush of enthusiasm. They become quite passionate early because it's something new. It's a new lever for many people. But really the benefit is long-term. I think organizations that use accreditation wisely, not in that tick box way, but want to use it as one of their levers to continuously improve and provide better care and services for their patients, can have a marked effect across time. It's that continuous improvement cycle that we often talk about that you've seen at many conferences that I think is where the gold is. And what's happened is accreditation, of course, itself has been changing, as we said, has been innovating and trying to add new, sometimes more challenging standards and new fit-for-purpose standards over time. So I think it's symbiotic, but I definitely think there's a practice effect and a longitudinal effect that you can benefit from if you're a hospital wanting to play the long game. Carsten, does that summarize what you would like to say, or do you have something else to add?
Yeah, I would add that this also means that accreditation needs to be contextual, and it's the onus lies upon the accreditation bodies to deliver standards and programs that address the problems that organizations really need, and that will differ over time and over places, and that's one of the reasons why ISQua has never tried to develop one set of, let's say, global accreditation standards that fits to everyone. I think it's important that there's a choice. You can choose the standards that address the problems that you face in a way that suits the way in which you work. And then again, we can't emphasize it enough. Don't do it to get a certificate. Don't do it because as a part of your improvement and management strategy.
Yeah.
We have another question here, which is probably reflecting on your report, which looked at almost 400 different studies, I believe, up to the 2023. I have two questions really. One is somebody who's asking the question about what are the references, and of course you will refer, I'm sure, to the report. But can you give us some insights about what tables or what kind of pages to really look at? And my thing, personally speaking, I know you introduced the second, watch this space, about the second report. Why did you? What do you expect to see? Sorry, let's put it that way. Maybe open.
Those are both great questions. One is look at the table where we've selected the top 10 cited accreditation papers over the last 40 or 45 years since accreditation, the first paper ever came into PubMed, into Medline. Mm-hmm. So we've synthesized literally every paper we could find, AI enabled. We asked AI to search through and say, what's this saying to us, and then checked it. So we got rid of any delusions that the AI made. But we've synthesized that. And then we said, which are the top 10 papers that we think are the top 10 studies? And then we said, which are the top 10 most cited papers? Because they both tell you something. One, the best evidence. And the second one, the papers that are most used by people to try and inform them. So I would look at those two tables if you don't want to look at hundreds of pages. And then this other thing I would do is look at the discussion where we bring it all together and only over a couple of pages, 2.5 pages, 3 pages, discuss what we think the literature's saying. That's in your QR code. So now you can go to that report and maybe make more sense of it, or use your time wisely. The second one you've asked is, what do we think we'll find in the next 2 years? Well, in one sense, Erik, it's too early to tell because we haven't released the report, but we expect to find some newer studies and some newer papers more in line with using accreditation the way that second panel showing on your screen is talking about, rather than the first one. So it's going to reflect the changing nature of accreditation, which Carsten talked about.
Okay, well, good. Yeah, and maybe, Carsten, if I may ask you, there's one trend that I, maybe just me being biased slightly, but that I seem to have spotted myself, is like when you look at the different people who professions working in healthcare administration, who seem to be, who are more positive inclined towards accreditation. I think always what strikes me is that it's often the administrators who are really pushing the boat out there. They're the most enthusiastic often, then the nurses, and then finally the physician. Now, I know you're a physician, so maybe I could ask you that. But any thoughts on that, or am I reading it wrong? Maybe I'm incorrect.
No, and I mean, from my own home country, Denmark, there's a very nice study that's demonstrating actually what you said. But there is one addition to that it found that the, let's say, the total result for physicians was heavily weighted by the fact that there was a small group of physicians that were very negatively, had a very
Yeah,
negative attitude towards accreditation. But I think one of the things we need, physicians, we need the messages we need to bring to physicians is you are embedded in a complex system, and the purpose of accreditation, and that was actually the purpose of accreditation all from the very beginning, almost 100 years ago, is to ensure that the system, the complex system within which you works, is able to support the work you are doing. We are not trying to tell you as physicians what to do. And when you engage physicians, that's my own personal experience in discussions about clinical quality and how to manage and improve clinical quality, they're very interested, and that's the way
mm,
to uh, to
thank
get
you.
their buy-in.
Thank you. So I think we're going to give people a minute or two back of their time. I'd like to close this session by thanking Carsten and Jeffrey and IHF Secretariat, Tom and Aditi and Ron, of course, very much, and all the other co-authors. And let me plug one more time our course as well, which is exactly, hopefully it may feature actually in your next report. I'm the course director for this lovely course on regulatory excellence in health and social care, which you can find on our links. And yeah, it's great to have a chat with you. And I hope we'll hopefully connect again soon. And thank you for all of you who joined us today. We'd love to hear from you, and please stay in touch. Thanks again, Carsten and Jeffrey.
Thank you, Erik.
Bye, everybody.